Thank you very much, ladies and gentlemen, Mr. Chairman. I'm quite happy to have the opportunity to talk about the role of LabIPOM and OpenIPOM. But I must say, I think still the gold standard, this is the wrong question, because the gold standard is defined as a standard which is based on a standardized procedure. And if you look on ventral hernias, we do not have a really standardized procedure. Laparoscopic IPOM and open IPOM. What's the topic we talk about? We had primary and ventral hernias as well as secondary ventral hernias and other problems associated with different hernia kinds. Comorbidity is different and the surgical technique is not standardized at all at the moment. The last point, I would like to recall the Physiomesh disaster during LabIPOM procedures concerns the surgical material. And this is the first point of my presentation. If you look what happens with polypropylene in patients in comparison with PVDF-based meshes, you see that the polypropylene meshes are degraded in the long term when they are implanted in the patient. This does not occur with PVDF-based meshes, polyvinylidene fluoride-based meshes, which I use since 16 years now. And this is also shown with different microscopic techniques. You see the detachment of the surface as well as the degradation and the break of the surface. Once more, this fact, and the polypropylene meshes are not only or are also degraded if you look on the titanized polypropylene meshes. Again, PVDF seems to be much better than the polypropylene meshes. Concerning open IPOM and laparoscopic IPOM, there's one very good paper, not only one, but this is a quite recent, very good paper from a Swiss group. They compared really comparable patients, 96 laparoscopic IPOM against 48 open IPOM patients. And what they found is that the recurrence rate is not different, but the main difference concerns the rate of surgical site infections. This is really much higher in patients after open IPOM procedures. And this is shown also in this table. I think I can pass the table. And at the end, the colleagues concluded that the laparoscopic IPOM should be the preferred technique and not the open IPOM because of the high rate of surgical site infections and perioperative complications as well. When we talk about the role of laparoscopic IPOM concerning the short-term morbidity, I like to concentrate on the ACS NASGroup database because the data are very well documented and they recruit a lot of patients. Such in this study, 117,000 patients, 22% have done by laparoscopic approaches, and they look for the perioperative morbidity, 30-day morbidity, and of course, they compare comparable patients by using logistic regression. And in this, this table shows that the use of open procedure is a major risk factor of increased perioperative morbidity. This is the main conclusion from this study. The use of laparoscopy can, in this study with 117,000 patients, significantly reduce the rate of reoperation, pulmonary complications, renal insufficiency, sepsis, and of course, superficial and deep wound infections. This is also true if you use laparoscopy in emergency cases. I would like to show you 3 studies of the last years, and they consistently show that you can achieve a reduced surgical site infection if you use the laparoscopic approach. Also in these emergency cases with incarcerated and strangulated hernias. The long-term recurrence and complications are very well documented by an analysis of the Danish hernia database. This database is compared with the National Patient Registry, so we had a 100% follow-up. The outcome parameters of this study were the risk of reoperation due to recurrence or any mesh-related complication after 5 years, and 3,200 patients were included in the study. These are the characteristics of the patients, but the most important thing is the risk of complication. And what you see is that laparoscopy increases the risk of major complications due to bowel obstruction in the long term. This is increased by double compared with open mesh repair. Clinically important complications are much higher, again, doubled in the open procedures compared with laparoscopic procedures, again, mainly due, but not only, to the surgical site infections and the sinus tract. So what the study clearly show is that the reoperation for recurrence is highest when you use open surgery with only suture-based, suture-based techniques compared to open and laparoscopic mesh-based surgeries. But nevertheless, the incidence of complications is highest in open surgery and lowest in laparoscopic surgery. A last problem concerning standardization of the laparoscopic IPOM approach concerns the defect closure, the laparoscopic IPOM plus procedure. We have some studies, but only really one very good study. And this is the study of Christopherson, published in this year in British Journal of Surgery. They did a randomized clinical study with primary umbilical hernias, and they compared IPOM with fascial and without fascial closure. And what they found is a significant reduction of seroma formation after 30 days and a significant reduction of the cumulative 2-year recurrence rate. They found 7% in the closure group versus 19% in the non-closure group. So this is the first really good study showing that the defect closure may be superior or is superior, at least in the repair of primary umbilical hernias. The trends in incisional hernia repair is analyzed in detail by Köckerling and colleagues using the HerniaMed registry and 61,000 patients. And the important thing is that 10% of these patients are treated by suture repair. Lap IPOM decreased from 33% to 21%. Open sublay increased, and the other techniques like Milos, EMILOS, ETAP, etc., increased from 4.5% in 2015 to 10%. Though the hype of LAB-IPOM is a little bit decreasing, but it seems to be stable at 21%. So in summary, the major series with well-controlled data quality and recent review clearly showed that the LAB-IPOM is associated with a lower rate of wound complication. That's the main important advantage of LAB-IPOM. But also long-term complications and reoperations rate are reduced. Reoperations can be performed safely. I could not show the data concerning this aspect, but this is also be shown in some papers. Of course, adhesions may occur and they may produce some problems with reoperations concerning obstruction. The defect closure should be the preferred option for laparoscopic repair, at least of umbilical hernia. So is there any indication for LAB-IPOM? Yes, I think there are good indications for LAB-IPOM depending on the size of defect. Of course, a recurrence after open repair is a good indication. Impaired and comorbid patients are very well suitable for these procedures, and previous deep wound infections, which are predisposing also wound complications, should be treated by laparoscopy, as well as pre-existing risk factors for wound complications. A really effective, safe, and long-lasting anatomic reconstruction should be recommended for active and heavily working patients, and this will work only with the open procedures using sublay or pre-peritoneal mesh placements for transverse incisions. And this has been published by Anil Sharma and me in 2018, the current role of laparoscopic IPOM repair and abdominal wall reconstruction. And I would like to conclude that there is a role of laparoscopic IPOM repair in abdominal wall reconstruction. Thank you very much for your attention.